Hello, dear colleagues. A warm welcome tonight for this EURETINA Case Club series, which is, as a matter of fact, the episode 2. We had the first Case Club event recently, which was conducted by Adnan Tufail and his team at Moorfields. My name is Frank Holz. I'm from the Department of Ophthalmology in Bonn, Germany, and I'm particularly happy that tonight we have a participating lovely panel with us for this Case Club. And perhaps we can have the slide and see the next slide. This is a glimpse of Bonn here. And again, an immense pleasure on the panel tonight to welcome Patricia Udaondo from Valencia. Sorry that Barcelona didn't win against Bayern Munich the other day. It was, a matter of fact, yesterday. And we have with us Sandrine Zweifel from Zurich. And we just learned that all the ski slopes are open in Switzerland. Thank you for joining. And we have Camiel Boon with us from the Netherlands, Amsterdam, Heinrich Heimann from Liverpool, and Giovanni Staurenghi from Milan. And without further ado, I may say at this moment in time that we have 1,581 registered participants for tonight, some of which will watch it later pre-recorded, but this is a fantastic number and interest in this pre-Christmas Case Club event. And with this, I ask our first speaker, Keri McLean from Liverpool, with their presentation on Unveiling the Masquerade. Keri, the stage is yours.
Thank you very much, Professor Holz. So good evening from Liverpool. My name's Keri McLean and I work at St Paul's Eye Unit and alongside the Liverpool Ocular Oncology Centre here in the UK. I work with Professor Heimann, who's on the panel, and I just want to present this case. I've entitled it Unveiling the Masquerade, so we can discuss through the differential diagnoses for this patient. So this is a 26-year-old lady. She presents with a 2-month history of painless reduced vision in her left eye. She has no other ophthalmic symptoms and she's no previous ocular history. She does have a past medical history of being diagnosed with complex partial seizures at the age of 6, and she was quite stable with anti-epileptic medication. Otherwise, she was in university education and she was training to be a primary school teacher. So on examination of this lady, the vision in her right eye was quite good. Her left eye, her vision had decreased to logmar plus 0.7. Her intraocular pressures were normal and her anterior segments was also normal. Her right posterior segment examination was normal. And then I'd just like to flick to, this is her left fundus. It's a fundus photograph showing a yellowy grey lesion in the mid-periphery infratemporally associated with pre-retinal hemorrhage, and as well as that there's exudates tracking towards the macula. And if I just show you a zoomed up picture of this lesion, it's approximately 2 disc diameters in size. There is some evidence of maybe increased vascularity of it, and it is elevated on stereopsis. So just if I flick to an OCT, so we did some investigations. So the OCT through the lesion demonstrates that there's a thickening of the inner retinal layers and some posterior shadowing. What can be visualized of the RPE and Brooks membrane, it looks intact and there doesn't appear to be any break of that or any drusen underneath. There's also intraretinal cysts. And then if we scroll up through the OCT image, tracking towards the macula whole way through, there's areas of subretinal fluid and exudates, and it shows that there's subretinal fluid underneath her fovea, which has resulted in the decrease of vision. So this is the fluorescein angiography, both early image and a late image, and it shows areas of hyper fluorescence just at the area of the lesion, there seems to be maybe some areas of multiple areas of focal hyperfluorescence in that area, and it appears to leak later on in the image. So if I just, we had then thought of maybe the differential diagnoses for this case. We thought, could this be a vasoproliferative tumor? But those tend to appear maybe more in the periphery rather in the mid-periphery. A choroidal neovascularization, Bruch's membrane was intact, and there was no areas of a sort of disturbance noted in the underneath in the choroid. And on the fluorescein angiography, it appears to be a retinal lesion. Could this possibly be retinal telangiectasia? And it's maybe a more unusual location for this as well. Retinal angioma. There appears to be multiple little areas of hyperfluorescence, and that's maybe not in keeping with that. A retinal macular aneurysm. The age of the patient, she was only 26, and she'd no other comorbidities such as secondary hypertension. So that might maybe exclude that diagnosis. So maybe just ask the panel if they would like to comment on what they think, if there's any additional differential diagnoses.
Perhaps if I may start, Keri, did you notice any calcifications on OCT within the lesion?
To that, so we can see there didn't particularly appear to be any calcifications within this lesion. Perhaps just at the maybe the area at the left-hand side of it, of the motive nasal, but not particularly.
On slit lamp, any hypopigmented lesions of the iris at all?
No, the anterior segment was normal. There wasn't any to note.
Any other questions from the panel?
Yes, just
Patricia.
one question. On the right eye, there is no other findings, no lesions similar, smaller, or any other similar lesions at all?
No, there won't. It was a unilateral presentation of this lesion.
So it's unilateral in this case?
It's unilateral.
And any other medical treatment? Not really, just the seizures at the age?
Just the history of epilepsy diagnosed as a child.
But it's not under treatment at the moment?
She was on anti-epileptic medication, but
okay, so she's following the treatment.
Yeah, she was very well controlled on that.
Did you see any cells in the vitreous or the anterior segment?
No, there weren't any.
And she was otherwise healthy, so she didn't have any fevers or whatever?
No, she was otherwise well. Apart from the symptoms of blurred vision, she didn't complain of any other ophthalmic symptoms.
So Camiel, your question is considering a perhaps inflammatory origin or lesion?
Yes, inflammatory or inflammatory malignancy, very broad.
Was there a specific cause for the seizures? Sorry, after you, Camiel.
There hadn't been any specific cause diagnosed for her seizures at that time. Just they were diagnosed as complex partial seizures.
Does she have cats?
No, I don't think she has cats.
No foreign travels to exotic countries? Probably not in COVID era.
No, I think she came close to Wales.
You mean like to the Netherlands?
Well, that is extremely exotic. That would worry me a lot.
That would explain it all, yes.
Yeah.
Perhaps you carry on.
No history of foreign travel that we were aware of. So the possible therapies, basically, we were dealing with a patient who there was a lot of subretinal fluid and exudates causing the visual loss. I suppose the possible therapies that we had thought of, so anti-VEGF injections into the eye, laser, photoproofing, photodynamic therapy, cryotherapy, or ruthenium plaque. And I suppose maybe there's quite a few of them that may be valid options. At the time, we chose to do photodynamic therapy. It's something that was available to us as a clinical treatment there and then, and it's not particularly, it's not invasive. It doesn't carry the risks of maybe injection into the eye with endophthalmitis risk, and also that the risks that come with cryotherapy or plaque. So we decided to proceed with photodynamic therapy. So these are two images. They are 1 year apart. So we've got the color photograph. On the left-hand side is from pre-treatment, and the one on the right, along with the OCT, is 1 year later. She had standard dose vertebrofin photodynamic therapy. It was double exposure with 166 seconds. And it shows after 1 year that there is resolution of the subretinal fluid, and hemorrhages have resolved, as well as that the exudates have not completely resolved by 1 year, but they're significantly less. And then if I go to this slide again, this is an OCT scan, 3 at 1 year apart. So it does show now that after 1 year, it appears that the lesion is very much a inner retinal layer, dome-shaped elevation of those layers. Underneath the RP and the choroid appears healthy, so it does appear to be a retinal lesion. The outcome of this case, so there was a clinically significant reduction in the size of the tumour by 12 weeks after the PDT. She had no recurrence of lesion or any development of any other lesions elsewhere at 5 years, and her vision was logmar 0.1 with glasses. Given the appearance of the lesion, we then referred her for genetic testing. She was subsequently diagnosed with tuberous sclerosis, with the specific gene mutation for that, and the MR of her brain also revealed subependymal calcification, which is in keeping with tuberous sclerosis. So we thought the diagnosis was that of a aggressive retinal astrocytoma. There are cases of that in the literature that looks similar to the case that we have shown you this evening, that have improved with photodynamic therapy as one-off treatment for that. And there are other cases in the literature as well, which show. So I was just wondering if there's any other comments from the panel on this case or on the treatment of it.
Thank you so much, Keri. Really fascinating case, brilliant presentation. If I may start off, what is thought to be the cellular origin for this tumor? I think at some stage it was considered to be undifferentiated glioneurocytes. Any thoughts on this? Hanno, Keri, you're the experts.
Yeah, I mean, I thought it was maybe of glial cells, but I'm not quite 100%.
Mm-hmm. I know you wish to comment on the cellular origin. You're muted. Well, maybe in the meantime, are there other questions? Perhaps, Keri, if you briefly wish to comment for our participants tonight, you made the double exposure time. What made you choose the dosing? What's the criteria for this? For the PDT?
Okay, sorry, I think I'm unmuted
Professor
now.
Heimann can help me with that question.
Yeah, Keri can certainly help with the imaging. I think she's the world expert on astrocytoma now. She reviewed everything, every single case.
Oh, well, I've reviewed all the cases in the review. Yeah.
Regarding the treatment, I followed Professor Förster's advice. So if you have a hammer, everything looks like a nail. So we've done PDT for all the vascular lesions, and it worked like a charm in those days. So we tried it. And only after I've done it, I found this article about the astrocytoma from the Shield series. And this is when the bell sort of rang, actually. So for these small vascular lesions, I think it's a very good treatment. Not in all of them, but some of them. And for astrocytoma, it's not very common, but obviously it works. 5 years later, not a recurrence.
Other question from the panel, Sandrine?
Yeah, a question from my side. So initially, when you decided to treat this vascular lesion with photodynamic therapy, you weren't aware that this could be an astrocytoma. You just decided because it's progressive, it's a vascular lesion, it might respond. I mean, it's clearly was a retinal lesion. So you decided that might have a good response to photodynamic therapy.
Well, I think that the lesion it came closest to are retinal vasoproliferative tumors, and they respond very, very well to photodynamic therapy. And that's difficult to do because in the periphery, this was a central one. And I think that the advantage of this treatment is that virtually zero side effects, other it doesn't work. Whereas anything else would be very, very invasive. So I think we give it a shot, and if it doesn't work, we still can go on to the other things. And it worked. So at the end of the day, it was just a sort of a shot in the dark. I really have to say that.
Yeah.
But very successfully though, and perhaps now with the limitation that verteporfin is no longer available at the moment. So, but
Yeah, for the first time today, I had a patient I wanted to treat and I couldn't treat.
Yeah.
And I just
It's
want
coming
to,
within a few months.
In a few months, coming.
February, February.
and I think that something is very important and we should underline is that due to their position, probably it behaves like a vasoproliferative tumor, I fully agree. And they respond pretty well to PDT. And the problem is that the location. So probably cryo could be another nice option, but compared to cryo, it's very difficult to access. So I think that something that we should underline is doing a treatment that could not damage more and have a highest chance due to the behavior. If it's not a typical astrocytoma, the response to treatment. So congratulations for the decision because not damaging and trying to get the benefit on the lesion for the exudation.
Yeah. Thank you for this well taken point, Patricia. For the sake of time, we will be moving on. And next presentation is by Anahita Bajka, an unusual cause of recurrent vitreous hemorrhage. Anahita, take it on.
Thank you very much. My name is Anahita Bajka. I'm a first-year resident of the University Hospital of Zurich of the Department of Ophthalmology. I'm honored that I can present you today this case of an unusual cause of recurrent vitreous hemorrhage. The patient presented himself initially as a 51-year-old male patient 10 years ago in our emergency department with vitreous hemorrhage in the right eye. Visual acuity at that time in the right eye was counting fingers at 1 meter distance, while at the left eye he had a full visual acuity. The patient reported prior episodes of decreased vision. However, his personal history was unremarkable. Also, no trauma was reported. 2 weeks later, after the vitreous hemorrhage reabsorbed, we could perform funduscopy nicely and see what's on the fundus, and we saw that there were extensive myelinated nerve fibers in the right eye with some neovascular abnormalities on the retina. Refraction in the right eye was showing that the patient is highly myopic with over -9 diopters, whereas the left eye showed a normal fundus with a refraction of only -1.5 diopters. In the OCT, we saw that the retinal vascular abnormality is especially overlying the internal limiting membrane infiltrating the vitreous. And you can see that the biggest abnormality that we saw was in the superior part of the myelinated nerve fibers, but there were also some other spots or regions affected in the inferior region. Here you can see once again a B-scan showing this abnormality of vascularization. Then a fluorescein angiography was performed, showing again this alteration here and also some smaller ones over here. The left eye appeared normal. Also, the peripheral images in the late phase of the fluorescein angiography showed no signs for retinal arterial or vein occlusion. So what is your diagnosis? In our clinic, we thought that that might be most likely a syndrome of myelinated retinal nerve fibers, myopia, and amblyopia, and that the changes, the vascular changes, are most likely due to the syndrome that had associated retinal neovascularization, which caused the recurrent vitreous hemorrhage. What are the treatment options? There are different treatment options suggested by the literature. One of these is argon laser photocoagulation. Another one is intravitreal anti-VEGF injections. Due to the extensive myelinated nerve fibers in this patient's eye, it's been decided to start a treatment with anti-VEGF therapy with an off-label use 10 years ago with bevacizumab. Here you can see the difference after the first anti-VEGF injection. We can clearly see that this supposed neovascularization has strongly decreased. The patient received then 4 more anti-VEGF injections, was unfortunately lost to follow-up in the following years. However, there was 10 years later, so this year we saw the patient again with a stable visual acuity, but again, a growth of the neovascular changes. Here you can see the differences before therapy in 2011, after the therapy has been started in 2012, and now again how the neovascularization has grown. However, the patient had reported no recurrent vitreous hemorrhage since therapy start, and also subjectively thought that his vision was stable. Here we have some other OCT scans that are a bit longer, 16 millimeters in horizontal and 12 millimeters in vertical, performed with the plexi, which shows once again the neovascularization nicely. With the plexi, additionally, we performed some OCTA imaging showing in the VRI slab that there are neovascularizations. The membranes are clearly seen. So in conclusion, that was a case of a syndrome of myelinated nerve fibers, amblyopia, myopia, which was associated with the neovascularization on top of the myelinated nerve fibers, which most likely caused the recurrent vitreous hemorrhage. In our case, it seemed that intravitreal injection with anti-VEGF therapy seemed to be a treatment option, which was well for the outcome for the patient. Thank you very much for your attention.
Thank you, Anahita. Absolutely fascinating. One question I wasn't able to spot on the OCTs, was there posterior vitreous detachment?
As I said, we've seen, so maybe we can go back to the...
And how many injections were administered?
In total, 4 injections.
4 injections.
Bevacizumab, so bevacizumab, yeah.
Excellent. Hanno, have you seen something similar before? Still on mute. Camiel, you want to comment?
Well, this is extremely extensive, these myelinated nerve fibers, but I can imagine that it could be some trigger to proliferation, but I've never seen it before.
No, I've never seen a case like that. Fascinating, really. So probably be one next week. Yeah.
Is there maybe question, Sandrine? Any thought the association with myopia?
I mean, there are a few cases published in the literature associated with myelinated nerve fibers, and the spectrum is from telangiectated vessels till retinal neovascularization, as in our case. And there is also one case actually published, maybe Anahita, you can actually move forward to the OCTs, where they applied anti-VEGF, but they stated that the vascular abnormalities did not change under the anti-VEGF therapy. In this case, it was published by Italian group, and the vitreous hemorrhage also cleared under the treatment, but the retinal with neovascular abnormalities did not change. And when you move one slide forward, I think that was a very good question from you, Frank. The question is the vitreous detached or not? Because you can clearly see that these vascular abnormalities grows on the back surface of the detached. You need to move forward to the OCT. So it was partially detached, and I was just wondering, maybe a question for the panel. I was wondering because he reported recurrent vitreous hemorrhage, and as we saw the patient first 10 years ago, we did like the anti-VEGF therapy, then we lost follow-up. He didn't have any treatment in between, just the 4 anti-VEGF injection, but no episode anymore of vitreous hemorrhage. And I just found it quite impressive that this neovascularization actually growed a lot, but didn't impose any further complications. We
probably
have a large series of patients with highly myopia, myelinated nerve fibers, but this is the only case we have in our department showing these vascular abnormalities.
Yeah, but probably what's happened is that since you know, after 10 years, the vitreous in some way detached, so there is no traction, and then that probably is the cause of not having the you know, vitreous hemorrhage. But how you explain such a you know, changes in the vascular complex? Do you think it's related to some you know, not completely, you know, development of the vessels due to the myelinated fibers, or what's your idea?
Everyone from the panel is welcome to give their comments as well. I don't have the solution. Yeah, I think maybe it's a combination. In this patient, the myelinated nerve fibers are quite extensive. And when you look at the vessels overlying these nerve fiber layers, they seem to be, from the diameter, they seem to be narrowed. I don't know if there is also like a localized ischemia in that area where we have these myelinated nerve fibers, leading maybe also to upregulation of VEGF, but probably it's a combination. What we haven't seen in our case that there were definite signs of vascular occlusion.
But you would consider ischemic drive for this process, at least contributing possibly. I mean, it's fascinating to see this so massively. Do you have a sense at what point this would compromise function? I mean, if you consider normal retinal nerve fibers, there may be also some mechanical issue here, and we always look at these nerve fibers as being a sign that doesn't matter whatsoever functionally, but to what degree may it compromise function?
Well, in the case that we published, the ones that you were saying, it was our case, and there was no ischemic retina, and there was a telangiectasia over the fiber layer, you know, the myelinated fiber layer. So we didn't have any explanation at that time why there was such a thing.
Excellent. We will be moving forward. The next presentation is by Francesco Romano, an unusual diabetic eye screening. Francesco.
Good evening, everybody, and thank you for the opportunity to be here with you tonight. My case is about a 55-year-old lady who was referred by our diabetes service in our hospital as she was complaining of some visual disturbances that were occurring especially with dim lights and while she was reading. She had a history of insulin-dependent diabetes of 20 years duration with good glycemic control and progressive hearing loss along the last decade. Her ophthalmic history was instead silent if we exclude these recent symptoms, but her last eye examination dated back to 2011 as their vision was preserved. On our examination, visual acuity was actually reduced in both eyes, particularly in the right one down to 20/63, while anterior segment and IOP assessments were unremarkable, except for initial nuclear cataracts in both eyes. But if we give a look at the fundus, we immediately see something unexpected from a diabetic patient, so no vascular abnormalities, but an extensive area in both eyes of macular atrophy surrounded by several yellowish subretinal deposits and pigmentary changes that did not spare or minimally spare the peripapillary area. These areas of macular atrophy were particularly evident on blue autofluorescence, while the yellowish and pigmentary alterations actually acquired the aspect of hyper and hypo-autofluorescent spots, comparing to the posterior pole and to the area just nasal to the optic nerve, a speckled autofluorescent pattern. OCT confirmed the presence of complete RPE and autoretinal atrophy, and with several autoretinal tubulations, while the apparently preserved retina actually had signs of elongated photoreceptors outer segments, namely ellipsoid zone, with some underlying hyperreflective subretinal deposits. We came up with some differential hypotheses, starting with some age-related degenerative conditions. First of all, pattern dystrophy of the RPE, although our patient might be bit too young for such an advanced scenario, or inherited retinal dystrophies. She did not refer any family history for genetic diseases, but late onset Stargardt might present with an autosomal recessive pattern of inheritance, and the course might be indolent. Mitochondrial retinopathy might fit our case as well, and this might even explain the diabetes and the hearing loss. While if we forget about the history of the patient and we focus only on imaging studies, toxic pentosome polysulfate maculopathy and rubella pigmentary retinopathy might also fit as well. I would like to ask the panel if they would give us their educated guess.
Personally, I would be very much inclined to say that it's mitochondrial retinal dystrophy in combination with the bad hearing and the fundus image. So I would go for mitochondrial DNA analysis.
Okay. So we decided to perform genetic testing for macular dystrophies and actually referred her to a GP for a general systemic workup. And this is the situation on her follow-up visit. So the retinal condition didn't change much, except from some slight enlargement of the macular atrophy, while blood levels actually revealed the increased plasma levels of lactic acid, and genetic analysis identified a single point mutation in position 3243 of mitochondrial MTTL1 gene. And so we formulated the diagnosis of mitochondrial retinopathy type 2 according to the latest classification. And we promptly referred the patient to our local mitochondrial disorder service, where they actually asked for a muscle biopsy for confirmation, as the systemic conditions seemed a bit too mild compared to the retinal phenotype. But before letting her go, we performed some angiography studies to better characterize the vascular alterations occurring in this disease. And if we focus on the late ICG studies, we can see clearly several areas of reduced fluorescence that reminded us of dark atrophy seen in Stargardt disease. But in our case, we see three different areas. So zone 1, zone 2, and zone 3. The first zone was characterized by complete loss of the RPE and of the choroidopapillary layers, while we also find an intermediate zone where we can see that the blue light autofluorescence is almost preserved, while the near infrared here below starts to be altered, and also the OCT angiography reveals some flavoids at the level of the choriocapillaries. So to conclude, I would like to stress how important is the ophthalmologist to identify such mitochondrial disorders in almost half of the cases, and how the related retinopathy still has many doubts, and actually their pathophysiology remains to be elucidated. And based on our single case, we also would stress the importance of performing some angiography studies in order to better characterize the alteration occurring at the level of the choroid. Thank you for your attention.
Thank you so much, Francesco. Fascinating case. And perhaps a question, if I may kick off. I mean, ERG is typically normal in this patient. It's confined to the posterior pole. Also, they may have compromise in dim light conditions and complain of glare. Are there any symptoms that would help you in the differential diagnosis at all?
Actually, when the diabetic colleagues came to us and said, she has very bad hearing loss, actually, this was a hint. And then for what concerns visual symptoms, I think they are quite unspecific, although, I mean, they suggest that it was something, the symptoms she referred, this was something that developed in time very slowly. Otherwise, if she had developed such an atrophic area in short time, maybe she should be much more symptomatic, not only in dim light, and maybe also for the everyday life tasks.
Mm-hmm. Camiel, question to you. Would you consider that this in mild retinopathy cases due to mitochondrial disorders, that is underreported if there is no other sign like hearing loss or anything else?
Yes, I think so, because it can be quite mild, as you say. So, and there is foveal sparing, so the patients are generally quite oligo or even asymptomatic. So I think indeed that they might be misdiagnosed quite often.
Mm-hmm. We have a question here from the Q&A room from Anna. Is it known why there is peripapillary sparing? Giovanni, you wish to speculate? Or Francesco?
Actually, I mean, in mitochondrial retinopathies, the peripapillary area is not spared in most of the cases, at least half of the cases. So, I mean, it's an affection of, it's a disease of photoreceptors, RPE, maybe a vascular impairment is involved. This whole thing might explain why the peripapillary area is not involved, is not spared in such cases.
Mm-hmm.
Yes, it's mainly the fovea that is spared.
Exactly. Again, I quoted from the chat, but it's an important sign also for ABCA4 related retinopathy, where the sparing is one of the typical features. One other question I would have: there are histological reports that there's a depletion of melanin in these mitochondrial retinopathies at the level of the RPE. Did this stick out in the near infrared autofluorescence mode that you saw more abnormalities?
Yes, it was very tough to acquire near-infrared autofluorescence actually images, and that might also be the reason behind the faint hypofluorescence in late ICG images. So there is, of course, some melanin reduction at the level of the RPE that when it starts to be affected by the disease.
Mm-hmm. Sandrine, do you see this as a differential sometimes? If these are elderly patients and have mild retinopathy and have atrophy, it's lumped into the basket of geographic atrophy due to AMD. Is that something challenging to make it a call?
Definitely, and as Camiel Boon already pointed out, probably many of these cases are just misdiagnosed, especially in the older age. I agree.
So if in doubt, it may be very sensible, as you did, Francesco, and your team, to prompt such a patient for mitochondrial analyses, molecular genetic analysis. Excellent. So
may I
move
Frank,
sorry, Giovanni, please.
I was trying, but I was working badly with the microphone. One of the things that I actually want to underline is the fact that, as you said, the area where the RPE probably lost melanin, even if it's still there, probably is a sign of not functioning. And in fact, in that area, there is a lack of choroidopathy. But probably it's related to the fact that, yes, the RPE is still there, but probably due to the lack of melanin is a sign of not working, and the choroidopathy is affected. So it's I think it's a very nice idea that this case suggests us.
Excellent, very well taken point, Giovanni. Next presenter is Mehmet Dogrüsöz on the topic of a yellow fundus. Mehmet.
Thank you, dear Chairman. I am Mehmet Dogrüsöz. I am a fourth-year resident in ophthalmology from the Amsterdam University Medical Centers, and I work together with Professor Boon, who is one of the panel members today. And I'm honored to present our mystery case entitled A Yellow Fundus, What Now? So a 45-year-old female was referred to our clinic because she experienced sudden vision loss in her right eye since 1.5 weeks. And she saw a dark spot in the center of the visual field of that eye. She did not have complaints of her left eye. She actually never had any visual complaints before. She did not have systemic complaints, and her general medical history was unremarkable. The visual acuity of the right eye was 0.2, whereas this was 1.5 in the left eye. We saw 1+ cells in the anterior chamber and the vitreous cavity of the right eye, but we did not see any other abnormalities, except for this very striking fundoscopic image of the right eye. We saw a yellowish discoloration of the macula, and we saw multifocal lobular yellowish subretinal lesions in the inferior and nasal part of the retina of the right eye. The fundoscopic image of the left eye did not show any abnormalities except for a preretinal vitreous opacity. So what would be your differential diagnosis at this moment, and which additional examinations would you like to perform? Are there any panel members?
I would definitely rule out an infectious disease, although these lesions are highly suggestive for lymphoma. But I guess you ruled out syphilis and other infectious disease.
Yes, I will proceed on to show what we have done. First, of course, we made an OCT scan of the macula, which showed hyperreflective accumulation between the neurosensory retina and the RPE. And also there was a detachment of the RPE, which was actually more remarkable in the inferior part of the fundus, which is shown on the lower pictures. We also made an autofluorescence, which showed some salt and pepper-like pigmentary changes, but actually did not provide us any useful additional information. The fluorescein angiography showed punctate hyperfluorescent changes, and also mid-peripheral blockage of fluorescein, which is actually more clearly visible, noticeable in these pictures. There was also some late leakage, as shown here. And the indocyanine green angiography also showed choroidal blockage of fluorescein mid-peripherally, and it seemed to correspond to the location of the yellowish lesions on the retina. So what would be your next step? There was already a suggestion to exclude syphilis and look for lymphoma. Are there any other suggestions?
In the chat, there's a suggestion to rule out tuberculosis.
Yeah. So we indeed did a uveitis screening, which consisted of serology for a lot of infectious agents, as shown here. and we did a chest X-ray. And additionally, we did a diagnostic anterior chamber paracentesis. And of all these additional examinations, only the quantiferon came back positive. There were no other abnormalities. The chest X-ray was completely normal, and also the IL-10, IL-6 ratio was lower than 1. So at that moment, this was actually our differential diagnosis. So the first two diagnoses have already been mentioned. So we consulted our infectious diseases department, and actually they said that the retinal lesions we have seen may be due to the tuberculosis, and they said that they would start a TB treatment, which was started. But still, we felt a bit at unease with this diagnosis of TB. So we searched up PubMed to look for reports of ocular manifestations of systemic lymphoma, and actually found several papers which included retinal images which were really comparable to what we have seen in our patient. And more strikingly, a couple of weeks before our patient presented, a paper was published in the British Journal of Ophthalmology about a patient with primary vitreoretinal lymphoma who had very similar OCT images. So the similarities were really striking, actually. So we consulted our hematologist and requested them to look for signs of systemic lymphoma, but they said they couldn't find any signs of systemic lymphoma and advised us to continue the TB treatment. We consulted another hematologist, but actually he concluded the same as his colleague. But we still were very at unease about this diagnosis. So we ordered a PET CT scan ourselves, and the PET CT scan showed remarkable abnormalities, including a thickening of the gastric wall, several spots in the liver, and a supraclavicular lymph node, which was accessible for biopsy. So we went back to our hematologist and asked them whether they could do a biopsy of this lymph node, which they have done. And the biopsy indeed showed a T-cell lymphoma, which was most probably due to HTLV1 positive infection because the serum test was positive. So we concluded that our patient had uveal infiltration due to a systemic T-cell lymphoma, which had its origins in an HTLV1 infection. And our patient was adopted. She was originally from the Caribbean region, where HTLV1 infection is more common than in the Netherlands. But unfortunately, our patient had already disseminated disease, so her lymphoma was classified as an Ann Arbor stage 4A lymphoma, which has a really poor prognosis with a median survival of less than 12 months. So in conclusion, we would say that sometimes perseverance is really mandatory to reach a diagnosis. And our advice, our take-home message would be to use PubMed when you're in doubt, and trust your gut, but never trust your hematologist. Thank you for the attention.
Excellent. Important key takeaway message for us. Brilliant, fascinating. If I may start off with a question to Hannah Heimann, I mean, in the unlikely case that there's no systemic manifestation whatsoever, is it a consideration to make a biopsy of such a lesion in the eye?
Yeah, I mean, actually, that's the likely case. So in a way, you were lucky that she had manifestations elsewhere, because usually you only have the eye manifestation. And if I look at that picture, that's a textbook picture for vitreoretinal lymphoma. This is a take-home message for everybody on this session, really. Look at these pictures, and if you see that, that's almost pathognomonic. But the hemato-oncologists will not do any treatment without a tissue diagnosis. So you, as a little ophthalmologist, telling them this is lymphoma, the patient's gonna die, do something, is no good. You need a tissue diagnosis. So you have two options. Number one would be do a vitrectomy and remove the vitreous in front of these things. And you hope that you have a spillover of cells into the vitreous that you can harvest. But this is negative in a lot of cases. That's really a shot in the dark. But at the end of the day, what you need to do, you need to go into one of those blisters and they're like milk, and suck it out. And then you get the tissue diagnosis. But it is messy. You probably need silicone oil. And most importantly, you need a pathologist knowing what they're doing, because there won't be many cells. I had patients like that, not being able to walk through the door because they had CNS lymphoma and they have been seen for 6 months and no diagnosis has been established. So this picture, everybody please take it home. This is lymphoma.
Yeah, I would like to make a comment. I fully agree that it's a systemic condition, so it's not just the prognosis of the eye. So just remember the leopard skin fundus is typical, I agree. Second, I don't know in your department, but when we are doing biopsy of the vitreous, we usually have to talk to hematologists first, because it's very dedicated to maintain the samples so the cells are lost. So we usually talk to them to be ready. We have a special samples for this kind of cytology. So it's important to talk to them first. And another things that I would like to just a friendly reminder is that we are usually associating quantiferon to TBC, but it can be elevated when there is any kind of lymphadenopathy. So congratulations to keep trying to look for the primary lymphoma. And remember that quantiferon can be also elevated when there is other condition with lymphadenopathy.
Mm-hmm. Camiel, did you consider in the early phase when you saw the patient to go for a biopsy? Or as Hanno said, for a liquid biopsy, so to speak?
We could have, and maybe we should have, but because the clinical picture was so typical, I personally went to the hematology discussion and showing them the one-on-one images, and 2 hematologists have seen the patient because we asked for the second one to take a look, and still they said, no, it's not lymphoma. So at that point we could have done a biopsy, but instead we did a PET CT scan, and that woke them up. And that spared us vitrectomy with oil, but indeed it's a very good point of Hanno that you should really think about it, especially when the CT would be negative, or the PET CT scan would be negative, I think.
Yeah, so I mean the point of vitreoretinal lymphoma, most patients die within a year. So really it's more about the vision in these patients. And the second thing is the hemato-oncologists need the tissue diagnosis for their therapy. It varies from sublymphoma to sublymphoma to sublymphoma, what they're doing, which kind of chemotherapy, don't ask me what, but this is what they tell us. So just sort of some type of ratio is not enough for them. They need the tissue diagnosis.
If I may have the question again to Hanno, so if you do a small retinotomy and take out cells, how good is the yield? Also asking Patricia, how often then they make actually the diagnosis?
Yeah, I mean, it really is absolutely essential to communicate with the pathologist, and I highly recommend having a pathologist specialized in lymphoma, so not your usual one. So this is an art in itself. It's a subspecialty, and these cells are very brittle. They die on your bench. So it has to be really well organized from the biopsy to the lymphoma pathology specialist to get the diagnosis right. Otherwise, I can guarantee you get a report like, oh, some lymphocytes probably inflammatory. That's your usual.
Not enough sample, not well preserved or whatever like that. I fully agree that is very important. If you decide to do the biopsy, talk first to the pathologist, hematologist, or whomever is going to analyze the sample. Yeah. Otherwise, it serves not for nothing.
Thank you so much. We will, for the sake of time, we have to move forward. And I'm now glad to call Damian Garcia-Teillard on choroidopathy in a 24-week pregnant woman. Damian.
Good evening, everyone. I'm Damian Garcia-Teillard, and I will be presenting this case alongside Dr. Patricia Udaondo. So first of all, before starting, I'd like to thank you, Professor, and thank you, everyone, for this opportunity. So today we're talking about a 36-year-old female on her 3rd pregnancy, complaining about sudden vision loss on her right eye. As medical history, we have systemic lupus erythematosus, lupus nephritis, and 2 previous abortions. She was being treated at that moment for her lupus with hydroxychloroquine, azathioprine, prednisone, aspirin and enoxaparin. So basically she was on immunosuppression. She was on her 24-week pregnancy when she was referred to obstetrics for preeclampsia, having a blood pressure of 160/90 and proteinuria of 1.88 grams per liter. So obstetricians changed the treatment, having Ramipil and Labetalol for hypertension, magnesium sulfate for possible seizures she could have, and azathioprine and tinzaparin for increasing immunosuppression. But blood results showed this, thrombocytopenia and elevated liver enzyme. So in the end, obstetricians decided to carry on with pregnancy interruptions. But as we said, we were called because she was complaining about her visual loss on her right eye. Visual acuity for right eye was 20 out of 40 and 20 out of 20 for left eye. Here we can see the multicolor image showing a retinal neurosensorial detachment, which was confirmed by an OCT for right eye. This neurosensorial detachment was partitionated in the inside, showing hyperreflective material and an impressive increase in thickness of the choroid. Angio-OCT didn't really show any interesting or clinical relevant results. So basically, as main differential diagnosis, we proposed Lucas choroidopathy, which is choroidopathy plus neurosensory retinal detachment. It is rare, but it can occur in severe or hypertensive disease. And also serious retinal detachment associated in this case to the preeclampsia the patient was suffering. Here we have the first-in angiography images showing hypoperfusion in early phases, and the green andocyanine that we also asked, showing hyperreflective in early stages and hyperreflective for intermediate to late stages. This left eye here. Okay, so basically here we have the summary of what happened, how the patient responded to treatment and also to the interruption of her pregnancy. We can see how 5 days after interruption and treatment, this is the image we have of the OCT, 12 days and resolution at 20 days. So as we said, we have this possible differential diagnosis in between lupus choroidopathy and serous retinal detachment. In our case, we think it's a lupus choroidopathy, but as we said, like, we really would like to know your opinion. In our case, in favor for lupus choroidopathy, we have the choroidopathy, the neurosensory retinal detachment, and hypertension, having a thick choroid, and the images that first in angiography and green would findings. Against it, we'll have the fast recovery she had. And for the side of preeclampsia, serious retinal detachment to preeclampsia, we have in favor the hypertension in her pregnancy and the nice and fast response to hypertensive treatment that she had. It was like 20 days almost. Against it, we'll have we didn't have other vascular findings showing like hypertension such as haemorrhage or vitreoretinal abnormalities, and that it is usually a bilateral condition, and in this case it was unilateral for right eye. Here's a summary of the images again, before and after treatment. So as we said, we think it's a lupus condition, but we'd like to know your opinion. And to conclude, lupus choroidopathy is considered as a systemic activity score. It is an indication for aggressive immunosuppression, and if immunosuppression is not enough, we can end up having a PDT treatment for the eye. Most cases will have a complete resolution with an immediate and appropriate treatment, and late intervention could lead to permanent vision loss. I don't know what you think about this. Thank you very much.
Thank you so much, Damian. Really great case. Perhaps I may start off with a question to Camiel. We've seen this massively thickened choroid. Do you see this to regress in preeclampsia, or is this variable? How do you see the role here in this case?
Yes, I've seen it only a few times in pregnancy, these clinical pictures, and I understand the doubt between the two options also in this case. But it's also my experience that very soon after the delivery, things quiet down. It's such an amazing presentation. So yes, in my experience, which is limited because it's so rare, the choroidal thickness goes down. But yeah, it's a very interesting case.
Mm-hmm. There's a question from the Q&A. Was there evidence of active lupus reduced complement levels?
That's a very good question. The complement was normal in that moment. That's why the treatment was that. It was a really low dose for azathioprine to be pregnant because it's a high risk condition for women. The problem is that the blood test worsened after introducing the hypertensive treatment. And probably hypertension is the trigger factor, as Camiel was saying. So probably hypertension was the reason why we have the condition and we have reasonable doubts for everything. But increasing the immunosuppression, we hadn't enough time to see the results. So we have the doubt of clinical evolution due to the treatment because obstetrics didn't want to wait. So probably it can be two ways of similar manifestation of the same. I don't know. We still have doubts about the real diagnosis.
I have a question about the fellow eye. If you show the ICGA, I think there is also some changes in
there are mild changes.
Left eye.
Yeah, there are.
Which is not surprising, I guess.
Mm.
Yeah.
Go on. It's no. The next one, next slide. Next one.
Here,
This one.
exactly this one.
Yeah, it's very mild.
Yeah,
but
it's
we
mild,
also
but
see
yeah.
the choroidal changes. Yeah.
But
What do you think, Giovanni?
Pardon?
What do you think, Giovanni, or Sandrine is making a
Well,
comment?
I think it's it could be, you said it's monolateral, and one is the reason why you think was not preeclampsia, but it's actually bilateral. So it's more evident because there was the fluid under the retina in the right eye, but also in the left eye you have some lesions.
Yeah.
Sandrine, you had a comment.
Yeah, I also wanted just to stress out that there is like bilateral involvement. Interestingly, in this case, you don't have a lot of cotton wool spots or other signs of preeclampsia, and you don't have like any vascular occlusion. It seems really more to affect the choroid in this case.
Yeah, thank you. You are totally right. The imaging shows the choroid mainly taking part in the disease. Yeah.
Mm-hmm. There's a question from the chat from Dr. Schlingerman. Why do you have to choose between the two diagnoses? Could it be both factors compromising the choroid together?
Yeah. I agree. I fully agree. Maybe just considering the changes in the systemic treatment, but it's not our responsibility at all. Yeah. I agree.
Mm-hmm. Excellent. So last but not least, we have one more case to be presented by Philipp Herrmann, and the title is "It Runs in the Family." Philipp.
Yeah, good evening, everybody. It was really a pleasure to follow this up to this point. Really great. I have a last case to share with you. It's from our IRD clinic that I saw with your hospital quite a while back, and it puzzled us, so I want to share it with you. So it was a family coming in, and the parents were concerned for their children. Obviously, the children had decreased vision for a long period of time, and I felt the parents were quite relaxed about it. So it was a strange situation in a way. So we had a look at the children, and that's the first boy. It's two boys, and as you know, the vision is 0.1, 0.25, so severely impaired. The fundus, no severe abnormalities, rather fair with not a lot of pigment, and the 55 autofluorescence fairly normal as well. But in the OCT, you can see there's a lack of a foveal dip, so one could call that foveal hyperplasia. The boy, around 11, 12 years old, was doing fine. He hadn't noticed any deterioration over the last year, so he was quite relaxed about the situation, but still, they wanted to know what is really going on. Now his brother, 2 years older, had the same problems as his younger brothers. The fundus was really fair with a lack of pigment, and as you can see in the autofluorescence, there's no macular pigment, and also here lack of foveal impression, foveal hypoplasia. Both children complained, like if you ask them what is bothering you, they both complained about being blinded by light, and that's the photophobia was the most severe thing. There were a few other things, but they weren't really telling, but photophobia struck out as the major chief complaint. What's different in this boy here is that he had heterochromia of the iris, as you can see here in the picture, and he had hearing problems. Since early childhood, he was wearing cochlear implants, was doing quite well with it, but that was the difference between the two, but both looking very similar, obviously brothers, both really light skin. And in our ID clinic, of course, we draw a pedigree, and we started off, and what we found is actually that the parents had problems as well. So looking at the father, we saw a clear RP phenotype with some bone spicula and periphery, not a whole lot, but some, and an autofluorescence here with the 55-degree autofluorescence, which is really revealing the metabolic changes and dysregulation of the whole fundus also centrally. You see in the OCT how all the outer retina is lost to a severe degree, and that little that is left centrally, he's not so lucky. He has an edema, which you often see in these cases. He's never had treatment with eye drops or Trusopt or acetaminophen orally, never taken that. So that's the father. And looking at the mother, it was a completely different phenotype. So she had a huge atrophy, hand movements in both eyes. In the OCT, you see complete loss of the central retina. So we were a bit puzzled what to make out of this, right? I mean, obviously you have 3 different phenotypes in one family, and we didn't really know, what to do clinically. On the good side of things, it was a relaxed family. Obviously, the parents had gone through their life with disabilities, and they were pretty relaxed about their children. But I mean, what would you do? I mean, I guess everyone agrees one would do genetic testing, and that's what we did. We did NGS testing with Hanno Bolz from Senckenberg Center in Frankfurt. So looking at the father here in the black square, he was pretty straightforward for a dominant trait and dominant mode of inheritance. And he was found to have a mutation in rhodopsin on 1 allele. So his mother had RP as well, his uncle and his granddad. So you see 3-generation dominant RP, and rhodopsin is one of the most prominent genes to cause this dominant form of RP. Now, looking at the mother, it's always hard to tell when you have a late-stage atrophy. Many things look very similar. She was pretty young for that sort of large area, and in her 40s already gone, but it's staggered. She has a biallelic ABCA4 mutation, and segregation to her parents revealed both of the parents having 1 allele with an ABCA4 mutation. So that's solved, and that's obviously nothing really extremely uncommon. But what to do with the children now? I mean, obviously they've had a rather stationary process that's been going on through the whole childhood, and then you have this deafness, and we couldn't make anything out of it again. So looking at the genetics, we found a mutation in CACNA1F in the first boy, and that's causing congenital stationary night blindness, and it's located on the X chromosome. So obviously there's no male-to-male transmission. Looking at the mother, she was carrier of that mutation, and then looking a bit further up to the grandmother, she was carrier as well. And there were a few male people in the family, some of them already stated, that had this disease or were speculated to have the disease. So that makes sense, especially the photophobia and the stationary nature of the disease could work quite well. But this mutation was not found in the other boy. And we had to do another round and talk to our colleagues, geneticists who run this NGS panel. And they found eventually a mutation in MID-F. And that's something I never encountered before. but it's a transcription factor, and it causes Waardenburg syndrome, which is associated, as with many transcription factors, in different systems with different severity, but is associated with deafness and obviously a very sort of lack of pigment in the eye and very pale skin. And so that was interesting. Now, this is the mode of inheritance for this gene is normally dominant, but looking at the parents, they did not carry this gene. So what most common speculation would be it's de novo, it's new. So take it home message for everyone. NGS gene sequencing is really important, and we couldn't have solved this. We found here this different mode of inheritance with ABCA4 as a recessive form and rhodopsin as a common dominant RP form, also an X chromosomal form for a rather stationary process like congenital and stationary night blindness. And rarely, de novo mutations are possible as well, as here in this MIT-F mutation for microphthalmia-associated transcription factor. Thanks very much for your attention.
Thank you very much for the great presentation, Philipp. So obviously a living textbook, this family, quite amazing. Camiel, what do you think?
Oh, what can I say? I'm blown away. This is like the rarest of coincidence, right? I had no idea at the beginning, and I now understand why. It's very interesting and extremely rare. Wow.
Yeah, it's like a good case for a book, because you have different sort of stationary, and that's what we see. You know, we see stationary processes and we see very progressive processes. We see different modes of inheritance, and we all see in one family. What I found really interesting about this family was really the fact that they were really relaxed about it, because usually if you have parents coming in with a young child and an IRD is on the table, we have to discuss this. Things get touchy and are difficult, but they were completely relaxed because
I wonder where the parents met. I mean, they both had an eye disease, maybe at the patient's meeting or something.
Yeah, probably. Yeah, I heard that was more common in the past, but I don't have a lot of patients like this.
I mean, really impressive case. Congratulations. I just have one comment. You stated in the beginning that the son has foveal hypoplasia. I mean, just based on the OCT, you know, you could also say it's a fovea plana. It's a whole spectrum, but of course, vision was decreased in this patient, and there was also optic pallor. But in general, just based on the OCT, maybe just for the audience, fovea plana can actually occur in up to 30% of the children, and doesn't need to be associated with an abnormal visual acuity. Can be just be an underdeveloped foveal pit, but doesn't have to have a clinical impact.
Yeah, excellent point, Sandrine. And in your experience, there are several degrees of foveal hypoplasia. How do you see the vascularization of this hypoplastic fovea that we now easily visualize with OCT angiography? Do you see a connect to function based on the vascular abnormalities?
This is a difficult question. I don't have a good answer to it.
It's early days because we didn't OCTA many of these in the past. Question to Philipp: foveal hyperplasia and association with impairment, functional impairment.
It's an interesting one, definitely. I mean, here we have had a problem with a transcription factor, and I remember one patient with a mutation in PAX6, which is obviously as well a transcription factor, and they've had hyperplasia as well, and they can go from like complete malfunction of the eye to just a little, almost nothing. And interestingly, with Christina Hess, we made a study here on patients with Alports who have carry mutations in genes that encode for collagen. And you know sometimes how they have a temporal thinning, but they also have foveal dystrophy, let's say this way. Like it seems to be an embryological thing that they have like severely changed foveas, and they live with it very good with high, you know, most of the times with very high visual acuity.
There's one question from the audience. Don is asking why sector heterochromia? Neural crest related is the question.
I don't know. I don't know. It's associated. There seems to be, some changes in pigmentation as we saw it in the fundus, but I don't know why it's only sectorally. No idea.
Yeah, but what was striking was exactly the same location of the pigment distribution from the fundus and the iris. That I don't know why.
Maybe also with respect to the audience, Giovanni, you wish to comment how useful autofluorescence imaging is in working up such a family? Well,
as you know, autofluorescence gives information about the RP, and I think it's always important. And the difference blue and green autofluorescence can actually help us also to visualize the macro pigment, and you can actually measure the macro pigment in that way. But sometimes it's related to the fovea and the characteristic of the fovea. So I think it's the best way to understand the function of the RP and all the autofluorescence. We talked before about also the near infrared autofluorescence that visualize melanin and in some way probably give us the information about the functionality of the RP. So you need it in any way.
Thank you, very well taken point. So we love to offer treatment for these conditions. Question to Camiel after Lux Turner for the allelic RPE65 mutations. What will be the next on the market that we could possibly offer these patients? What's your guess?
The recent Biogen studies were a bit disappointing. So actually, choroideremia and RPGR. So I'm not sure. I think it's very important to still realize that with regard to gene therapy, it's early days, and that it will not be a bouquet of successes. So I don't dare to say which one it will be. There are some other RPGR trials also running. Let's see. I wouldn't bet my money on one thing.
Philipp, final word on that one.
Yeah, I agree. Definitely, same spot on. If I would have to, if you would force me, I would still say that the second RPGR trial has a good chance to go in a phase 3, then finally worldwide trial. But you're absolutely right. We have to be careful and look how things develop.
Yeah, so obviously a mixed bag. We are a little bit over time, and I wish to thank the panel and particularly to the presenters who have been absolutely fantastic. And at least I learned really a lot, and thank all for the EURETINA fans joining this evening, and you can spread the word. It will be able to actually listen to and see this case club later on. It will be readily available on the EURETINA website, and it's a great pleasure to announce the 3rd episode of the case series, and this will be hosted by Professor Ramin Tadayoni, obviously in Paris. And finally, we do hope that in terms of EURETINA, we will be meeting all live again next September in Hamburg, in beautiful Hamburg, where our new chancellor is actually coming from. And so hope we will see us then. And we do wish you very nice holidays coming up. And of course, do stay safe and stay healthy. Thank you so much. Bye-bye. Good evening.
Bye-bye.
Bye. Thank you.
Bye.